So good evening, everyone. I hope everyone is fine, and I hope your afternoon is going on well and your day was fine. I'll be your moderator today, the organizer of the sessions on BHMC, and today is our 16th session. It's our second month of the training, and I'm happy that today we'll be joined by Dr. Martin Macharia, who will be taking us through the topic of preterm birth. And I know everyone is expecting to learn more, so I would request you to kindly stay muted if you are not speaking, or if you don't have question, you can use the chat box if you have a question. And if also you have an inquiry, you can ask me. So without wasting time, because we are 10 minutes late, I would like to welcome our speaker, Dr. Martin Macharia, who will be taking us through the session. So welcome so much, Dr. Hello, Dr. Macharia. You can unmute.
Hello.
Hello.
Can you hear me?
Yes.
Can you hear me?
Yes.
Can you see the screen? Is there
Yeah.
anything shared on the screen?
Yes.
Titled miscarriage.
Preterm birth and stillbirth.
Okay. So can we start?
Yes. Yes.
All right. My name is Dr. Macharia and obstetrician gynecologist, currently working at the Kijabe Mission Hospital. I am going to be probably very brief about these three. They're big topics, to be done in the given time. And I do realize, of course, also that 2 hours is a bit of a long time for people to hold attention in a discussion. I also do recognize, of course, that this is not a medical group, and I'm going to try and be as non-medical or as simple as I can, and of course clarify whenever there are questions. So I am going to go right ahead. I have arranged them in the way that they occur as complications in pregnancy, and I will start off with miscarriage. By definition, miscarriage is the involuntary expulsion of a fetus or an embryo, as it may be. An embryo here refers to the product or the product of conception up to around 8 weeks. That is the first trimester. Is there an echo in my? Hello?
No, you are clear.
All right, fine. All right. So up to about 8 weeks of a pregnancy, that is called an embryo. After the parts or the body parts are formed after the first trimester, we generally refer to it or the baby as a fetus. So the involuntary expulsion of a fetus or an embryo from the uterus before it can independently survive outside the mother's body. Now, for a baby to be able to independently survive outside the mother's body, it has to be at least 500 grams or about 20 weeks of pregnancy. We know that pregnancies generally take about 40 weeks when they're term. And so 20 weeks is just halfway through the pregnancy. So in very good hospitals or units where the neonatal care is very good or the nursery care is very good, babies weighing 500 grams or 20 weeks may be able to survive. And that is why we anything below that, we call it a miscarriage. Above that, we will call it something else, probably preterm labor, as it may be. So to differentiate between, the term abortion has been used in medical language to mean both the involuntary expulsion and the voluntary one, where somebody may choose to terminate a pregnancy. But miscarriage is now, being accepted also medically to mean, as medical language. So we it's socially not very acceptable to say abortion. So we are more or less using miscarriage now. It is the most common early complication of pregnancy, and usually the occurrence of miscarriages will decrease as the pregnancy grows bigger, meaning that if you're at 10 weeks, you're more likely to have a miscarriage than if you are at 16 weeks of a pregnancy. The incidence or the commonality of miscarriages is about 20 weeks, 20% before the pregnancy gets to 20 weeks. But 80% of those miscarriages, of that 20%, will actually occur in the first 12 weeks, or what we call the first trimester. There are also a lot of miscarriages that occur before a pregnancy is even diagnosed, before you even know you're pregnant. You probably missed your period by a few days, before even a week, and then you start bleeding, and the bleeding is a bit heavier than your usual, and it turns out that it's a miscarriage, but it's occurred very, very early, before you had known that you are actually pregnant. What are the risk factors for miscarriages? If you go by age, age is actually like a risk factor for miscarriage as an independent factor, and people who are in their 20s and 30s, or early 30s, the miscarriage rate is about 15%. By the time you get to 35 years, your risk of getting a miscarriage in a pregnancy is about 20%. 40 years, you have like a 40% risk of getting a miscarriage. And by the time you are 45 years, you have a very, very high risk of your pregnancy ending up with a miscarriage. A previous miscarriage is recognized as a risk factor. There are social factors, like smoking, which will be a recurring theme in a lot of this presentation. People who smoke more than 10 cigarettes per day are at a very high risk of ending up with a miscarriage. High alcohol consumption, moderate to high alcohol consumption during early pregnancy, drug use, cocaine and other drugs of abuse are also social factors. Maternal infections that result in fevers, usually of more than 38 degrees. Some prescription drugs you may take, especially in the first trimester, may actually end up with a miscarriage. Some nutrients, especially folate, when they are low in your system, may actually result in a miscarriage as well, especially first trimester miscarriages. And then we have the causes, those who are risk factors, but we have some known causes of miscarriages. Chromosomal abnormalities refer to your body is generally composed, or whatever your body is composed of is determined by what are called genes, and these genes are or come together or aggregate together to form what are called chromosomes. And these chromosomal abnormalities, you have chromosomes from the female parent and the male parent, and when they come together, now they form an independent composition of chromosomes in the baby. Now, if there are abnormalities in this chromosomal congregation, then you end up with a miscarriage. Whether you end up a miscarriage usually depend on how severe the abnormality in the chromosomes is. And we know that these chromosomal abnormalities are the commonest cause of first trimester miscarriages. By sporadic, I mean most of these chromosomal abnormalities occur randomly, meaning that it doesn't mean there's a problem with the mother or the father. It's just something that happens during the joining process of these chromosomes, and you end up with an abnormality that does not allow the pregnancy to survive. Congenital anomaly refers to the abnormalities, the physical abnormalities that a baby may develop. Most of them actually are as a result of these chromosomal abnormalities. Some of them may be due to other things like exposure to drugs or radiation or something like that during the pregnancy. And chromosomal abnormalities usually cause a miscarriage to a well-formed baby. This usually will be in the second trimester, commonly around 20 weeks or above. Then you have uterine factors. The uterus may have problems that may result in miscarriages. Septae are basically just dividing, the uterus is like divided into two sections, through the middle, so that you end up with the pregnancy occurring in one of the portions of the uterus. It's a small portion, so it may not be able to carry a pregnancy up to term, and you end up sometimes with the early pregnancy losses. Usually it will not be the first trimester. Again, it will be usually in the second trimester. Things like fibroids, purely sometimes because of where they are located. If a fibroid is located where a pregnancy implant, then you may end up with that pregnancy miscarrying. Cervical insufficiency basically refers to a weak cervix. Some people do have weak cervixes, either at birth, or when they are born, the cervixes are already weak, or sometimes as a result of some things that are done during their reproductive life. Maybe they had a delivery and the cervix tore. There was a tear that was not repaired. That cervix that cervix may be a risk factor for a miscarriage in subsequent pregnancies. Infections in the mother, that mnemonic torches just refers to the commonest various infections in the mother that may result in a miscarriage. Toxoplasma, rubella, some of them you may have heard about them. Some of them are just CMV, herpes, syphilis. Some of them you've heard about them. These could be infections of the baby or of the placenta. Any of the two may actually end up causing a miscarriage. Maternal hormone disease or conditions, thyroid diseases. There's a gland called the thyroid that is just in the front of the neck. The hormones it produces are important for the general body metabolism, but also for pregnancy. And if they are deranged, either they are low or they're high, you may end up with a miscarriage. PCOS is called polycystic ovarian syndrome, a very common cause of infertility or fertility problems in many women. And also when people get pregnant, because of the hormone issues associated with it, it often results in miscarriages. It is notable that up to 50% of miscarriages may actually be unexplained, meaning that we do not ever get to know why the miscarriages occur, especially the ones that occur sporadic, that a miscarriage happens, then the next pregnancy, somebody conceives and they carry the pregnancy very well without any problems. Some of those miscarriages, we never really investigate them for one, and others, even when you investigate, we may not actually find a cause for the miscarriage, up to 50%. There's a clinical classification of miscarriages that sometimes we use, and you may hear them sometimes referred to by medical people. A threatened miscarriage simply means you're bleeding early in the pregnancy, usually before 12 weeks. And this bleeding, when you examine the cervix is actually, it's not a lot of bleeding. The cervix is closed. When you're examined, usually there's no pain or there's no cramping. And most of these little bleeding will stop and the pregnancy will continue. However, some of them the bleeding might increase and you end up with a complete miscarriage. Inevitable miscarriage refers to, the word inevitable there is just English. It basically means it will happen. There's no stopping it. And here there is bleeding, which is a significant bleeding. The cervix is open when you're examined. And there is significant cramping that results in the uterus pushing out the contents outside. Incomplete miscarriage basically is where some of the contents of the uterus, parts of the fetus or the embryo, as it may be, have been pushed out of the uterus, and some of them are still remaining. That's what is called incomplete. So you have bleeding, the cervix is open, there's quite a bit of cramping, and the pregnancy is partially expelled from the uterus, so some parts are still remaining inside. Usually it will happen in the first 3 months of pregnancy. And then you have the complete miscarriage. Here, everything has been pushed out of the uterus. The uterus has cramped and pushed out everything out. There's usually minimal to no bleeding after everything has been pushed out. So there'll be no cramping as well. And this is again usually before 12 weeks. There's what we call missed miscarriage. It is called missed because when a pregnancy is failing, either the baby is not growing, the baby has died inside there, the tendency of the uterus is to push the contents to the when that doesn't happen, when the uterus when the pregnancy fails but the uterus does not push the contents out and you don't start bleeding, then it is called missed miscarriage. And people will, and usually you will suspect that something is wrong because you feel that the abdomen is not growing, or the uterus is not growing. You've reached maybe 2 months, 3 months, 4 months, and the uterus is not growing. Maybe even the symptoms you used to feel, the nausea, the vomiting, the tiredness, have disappeared completely. Then you know something is wrong, and when you do an ultrasound, you find that the pregnancy was not growing. Can you hear me? Hello.
Yes.
Okay.
Yes.
All right. Then there's a septic miscarriage. Usually, this will happen. Septic just means that there's an infection in the uterus, and usually this will happen with an incomplete miscarriage. So you miscarry, and then some of the parts of the pregnancy are left inside there, and then because the cervix is open and exposed to the outside, the contents get infected, and usually the presentation will be you may have fever. You may have chills. Malaise just means, a feeling of general weakness and lethargy. You may have abdominal pains, which may be crampy in nature or not crampy. And usually, when you have an infection in the uterus, you have a discharge that is foul smelling. It may be pus, it may be just a foul smelling discharge of other nature. If not managed early enough, this may actually lead to more severe infections, e.g., salpingitis just means infection of the fallopian tubes. Where the eggs from the ovary usually pass to go to the uterus. The fallopian tubes, or peritonitis means the infection of the area around the uterus. And sometimes it can even go to the bloodstream, and you get a full-blown infection that can be very, very severe. It's these infections that go to the fallopian tubes and the area around the uterus generally are they are a very common cause of later fertility problems, because if the fallopian tubes are infected, they are very, very fragile, and they get destroyed easily, and that would mean that they close up, and you're not able to conceive later on when you may want to conceive. Commonly, they occur with the procured abortions, especially when they are done unsafely, and usually they are not common with the miscarriages that occur by themselves. The common complications of miscarriage are usually blood loss. This depends on usually how big the pregnancy is. Usually, if the pregnancy is small, before 12 weeks, the blood loss is usually not much. And if you're in the second trimester, if you're talking about 16 weeks, 18 weeks, and you miscarry, you may actually lose a very, very significant amounts of blood. And if you're not in a hospital, or you don't manage to get to a hospital in good time, it could actually mean you get to hospital when you're in very bad state. That may actually necessitate you even having blood transfusions. People have actually even died from that kind of bleeding. Infection, as I said before, this is usually in the case where an incomplete miscarriage is not completed in good time and you get infection in the uterus. And now, sorry. And of course, infertility in the future is also a complication of those infections. Those are the three common ones. Obviously, there are other issues associated with a miscarriage, like psychosocial issues. A pregnancy is a pregnancy, whether it's a small pregnancy or a full-term pregnancy, and a loss usually results in a lot of psychosocial issues for the mother and her support system. So how do you manage these miscarriages? Remember, I'm basically talking about miscarriage as as happening without choice, not the ones that are so I'm discussing management of miscarriages that happen by themselves or spontaneously. For threatened miscarriage, which we said is just some bleeding in the early pregnancy, usually there's nothing you can do. We do watchful waiting. We may sometimes advise you to take a bit of rest, not to engage in very strenuous activities. But in terms of medication and everything, there's actually nothing you can do about it, because, as I said, the commonest cause of those miscarriages are what are called chromosomal abnormalities. And if they are there, it will happen regardless of what you do. The miscarriage will happen. But I said also a good number of them will the bleeding will stop and you go on to have a normal pregnancy. Then inevitable miscarriage, once you determine that this pregnancy is going to come out, nothing will stop it, then you have to do evacuation of the uterus, and that is done either by medical means or surgical means. Medical means, you are given some medication, they cause the uterus to cramp or to contract and push the contents out. Surgical means maybe you go to theater and you get the contents removed from the uterus in theater. For an incomplete miscarriage, again, evacuation is needed, and it can be either medical or surgical again. Complete miscarriage, there's nothing you do, medically speaking. The only thing now you do is to counsel the mother, reassure her, and discuss the pregnancy loss, depending on the probable cause of the loss. For missed miscarriage, again, as I said, the one where you have the pregnancy is not growing, but you're not bleeding, and usually discovered by doing an ultrasound. And evacuation will have to be done again medically or surgically. For septic miscarriage, evacuation will have to be done, and this time usually we do not do medical evacuation. This one you usually will have to be taken to theater for it to be evacuated surgically, because the evacuation needs to be done as quickly as possible to prevent the infection from spreading. Medical evacuation by using drugs sometimes take a bit of time. It can take days, even a week, sometimes even more than a week. You don't want to wait that long with the uterus that is infected. So you evacuate as quickly as possible, and you give antibiotics as you do that, so that you tame the infection and avoid it spreading to the rest of the pelvis. There are some general principles of management of miscarriages that we have, what we take everybody through. Medical management generally means all those things that I've discussed there before in terms of management. That's what we call medical management. Evacuate to clear the uterus of whatever is remaining inside there. Hematinics are basically blood build-up products. If you have lost blood but not too much, you are given these medications to kind of build up your blood level again. You may have to have blood transfusion if the bleeding has been severe or you are unstable. Antibiotics if you have an infection, an infected miscarriage. So all that constitutes what we call medical management. Then you have contraception. Usually, these ladies, even though the loss was unintended and it's a big blow, most of the time they are not ready. Both physiologically, that means the body is not ready, and they're also not ready psychologically. Their mind is not ready to carry a pregnancy immediately after a loss. So usually we would encourage them to take a few months break, and within those few months, as they recover, they would need to be on some form of contraception, because if they resume sexual activity, they can conceive quickly again. And remember also, I said that those who conceive too quickly after a miscarriage or a pregnancy loss, they have a small increased risk of getting another miscarriage if you conceive too early after. Then of course you have the counseling, because this is a very sometimes even depressive affair, losing a pregnancy, even when it happens very early in the pregnancy. So a lot of counseling, both medical counseling and psychosocial counseling, is done for these ladies when that happens. A linkage to other reproductive health services. Usually, we like to also take the opportunities when we are managing them to try and see whether we can also do other things for them, like cervical cancer screening and sexually transmitted infection screening. So whenever possible, we try also to look that in and do it. Of course, at the comfort of the patient. And then, of course, we have consultations or referrals to other medical services. Those who may have other medical conditions, like say they have hypertension, they have other diseases, thyroid disease, they have diabetes. Some of them could have been the causes of this miscarriage, and we basically refer them to those who manage those kind of conditions so that they can get managed. I think in summary, that's where I will stop with the miscarriage, and I would invite questions maybe, or should I go ahead and maybe we save questions for the last, maybe after I finish presentation?
Yeah, I think the last option is the best.
Can you hear me? Okay, so I'll leave it there for miscarriages. If you have questions, please record them, and then we can address them at the end. So I'll go on to, yes, I'll go on to, sorry. I'll go on to preterm birth as a second part of the presentation. By definition, any delivery that happens before 37 weeks is termed as a preterm birth. Remember that generally speaking, a pregnancy that is, or the date that somebody is given for an estimated date of delivery is at 40 weeks. But when you have reached 37 weeks, that baby is said to be at term or at early term. And even if a delivery happens at that time, the probability of that baby being okay is very, very high. Meaning that the baby is unlikely to need any other care after delivery if they have reached 37 weeks. If the baby is delivered between 34 and 36 weeks and a few days before you reach 37 weeks, we call it late preterm. Moderate preterm between 32 and 33 and weeks and some days. Very preterm between 20 born at 2.5 kilos and above, we say that is normal weight. Babies born at less than 1.5 kilos, I'd say to be sorry. Babies born at less than 2.5 kilos are low birth weight. If they are born at less than 1.5 kilos, we call them very low birth weight. And if they are born at less than 1,000 grams or 1 kilo, then we call them, we say they are extremely low birth weight. Now, what is the significance of preterm birth? Prematurity, or babies who are born prematurely, most of them end up with issues, and prematurity is actually known to be the leading cause of early infant death or early death after delivery. Up to 30% of baby deaths after delivery is caused by them being premature at delivery. There is also a very significant cost when a baby is born premature, because nursery care is, especially for the very premature ones, is basically ICU care. It's like ICU care, but now for babies. And in most places, it's actually as expensive as the adult ICU. I'm sure you've heard of many cases of babies who are born very small. They ended up in the baby ICU or neonatal ICU, spent there 2 months, and the mother or the parents are getting bills of millions of shillings. So the cost of caring for a baby who is born premature is very, very high. And then there are the long-term sequelae of these premature deliveries. The development of the brain and the nervous system. They may end up with problems like cerebral palsy, impaired learning later in life, visual problems, and then a lot of them may have respiratory problems that sometimes may run through the whole of their lifetimes. They may have breathing problems or problems in their respiratory system. Of course, it's a major cause of stress, for the mothers. A lot of these mothers develop, psychosocial issues. Some of them may even become depressed or develop other psychiatric complications because of the stress of, being held up in hospital. They barely sleep. You are required to go to nursery, for example, to check on your baby, to feed them, to do what for a whole 2 months. And you're going there every 2 hours, including through the night. So you never really get to sleep. If you don't sleep for that long, the stress can mount up significantly. So these preterm deliveries are also a major cause of stress for the mothers and the caregivers. What are some of the risk factors and causes of preterm delivery? Again, you see, just like in miscarriages, smoking is a social factor. Alcohol and other drugs of abuse. Short intervals between pregnancies. If you deliver or you lose a pregnancy, for example, and then you're pregnant within a few months, there's a small increased likelihood of you ending up with a miscarriage. With a preterm delivery. Previous history of a preterm delivery means you're also at an increased risk of getting another preterm birth. Anemia, that is low blood level early in the pregnancy, is later on when the baby has reached a stage where it can survive outside, you may actually end up with a miscarriage. Hormonal issues, and these may be triggered by maternal or fetal mother or baby factors, like extreme stress, depression. Mothers who have those kind of conditions, actually may end up with a miscarriage, regardless of what is causing, that stress. If it's extreme stress, depression, they actually may end up with a preterm delivery. Infections, especially as I said before, with the high maternal fever, may cause the uterus to start contracting and result in a preterm delivery. Uterine abnormalities, like had suggested for miscarriages, like septa, which are dividing segmentations of the uterus. Uteruses that are small. Some people are born with the uteruses that do not develop to the required size. A lot of them are not even able to conceive, but when they do, some of those uteruses may not be able to carry pregnancies to term. The growth in the uterus, like fibroids, may limit the ability of the uterus to expand into the abdomen, especially when the fibroids are big. They may limit the space available for the uterus to grow, and when it reaches a certain point, the uterus basically has no option sometimes but to start contracting to expel the baby. Cervical insufficiency, again, just like for miscarriages, it actually can be a cause of preterm delivery when you have a weak cervix. And I say the weak cervix can be a disorder that you're born with, or that develops as a result of something that happened during a previous pregnancy or during a previous surgical procedure on the cervix. There can be placental issues, like a placental bleed or placental separation. Sometimes the placenta will separate partially. If a placenta separates completely from the uterus, the baby will die. You will end up with a stillbirth. But if there's a partial separation, sometimes the bleeding that happens inside there may irritate the uterus enough to actually initiate contractions of the uterus, and labor may start earlier than usual. Increased uterine distension, when the uterus is too distended, either because you have multiple gestation, you have 1, 2, 3 babies, yeah. 2 babies, tend to be born early, maybe by the time you reach 36 weeks, 36, 37, many women with 2 babies or twins will go into labor. If you have 3, most will go into labor by the time you get to 34. Rarely will a mother with the triplets ever get to term, really. So by 34 weeks, most of them will go into labor. If you have more than 3, you are talking about 30 weeks and sometimes even less when labor will set in, because the uterus is already very, very distended. If you have increased fluid in the uterus, or amniotic fluid as it's called, because of various problems. For example, a mother with diabetes, which is not well controlled, a lot of them will have a lot of fluid in the amniotic fluid, and this increased fluid, the uterus will, may reach a point where it is so stretched that it now needs to contract and expel whatever is inside there. Large babies, for example, again, in mothers of diabetic mothers whose sugars are not well controlled, large babies may be born earlier, again, for the same reason that the uterus is over-distended by the baby. Premature rupture of the membranes. When membranes rupture too early, before term or before labor starts, sometimes they may, the expulsion of the fluid may trigger the uterus to start contracting, and labor may start early. Sometimes you have a early delivery that is planned by the caregiver or the medical care provider for various reasons. People may have maternal diseases uncontrollable, for example, hypertension. One of them is what we call preeclampsia, very, very dangerous condition for the mother. And if it is severe enough, we sometimes opt to deliver the baby because the mother's life sometimes is at risk. Sometimes we deliver early also for baby reasons. We think the baby's life is in danger inside there, and if you don't deliver, there's a significant risk of the baby dying inside there. So regardless of the fact that you're delivering it by choice, or you're being forced to deliver because of those conditions, the baby will be born premature or preterm, and the same care that is needed for babies that are delivered without choice will be needed for these babies. And of course, there are a lot of unexplained, preterm labors resulting in preterm birth. We don't really get to know what the cause of the preterm labor is in a lot of pregnancies. The presentation of preterm labor is basically cramping. To start with cramping, and usually this will radiate to the back, the lower back. There may be some bleeding or just a little blood in the mucus discharge. The cervix, of course, will open or will be open and opening, continuing to open when we examined. And this is exactly the same way that labor at term presents. So the presentation does not change because the pregnancy is not term. It is exactly the same way that it presents when it's preterm. In terms of the management, of course, we usually assess the person initially. You ask questions about what is happening, then examine to determine whether really there are contractions and whether the cervix is actually opening. Then we may do some tests. For example, an ultrasound to determine how big is the baby, what is the amount of fluid inside there, how well is the baby doing, so that we decide the need to deliver this baby immediately or need to do something else before we deliver. Usually when you have preterm labor, you'll be hospitalized. Almost certainly you'll be hospitalized. Tocolytics are medications that are given to try and stop the contractions, especially if there's no bleeding and the fluid has not come out. There's no drainage of the fluid. Maybe it's just contractions. The uterus has started, the cervix has started opening a bit. Usually, we may give these tocolytics to try and see whether we can stop the contractions completely. A lot of times we succeed and we manage to push the pregnancy much further forward. And sometimes we don't succeed despite you giving these medications. Sometimes the pregnancy or the labor will continue and the baby will be delivered. Steroids are medications that also will be given when you have preterm labor, especially if it's labor occurring before 36 weeks. And these steroids generally are to help the baby's lungs I'll use the word mature. And when the lungs are mature, they are able to expand nicely. When the baby is born, usually the baby, when it is inside there, they don't use their lungs to breathe. So and their lungs are usually collapsed when they're inside the mother's womb. When they're born, when they take in their first breath, usually the lungs will expand and take in a lot of air inside there. If the lungs are not mature, though, they may be unable to expand nicely, and the babies will have breathing problems, some of which may be major breathing problems. So these steroids, which are given as injections, are given to help the baby's lungs to mature, so that in case we are not able to stop the labor, or in case we decide that it's not safe to try and stop the labor, the baby will need to be delivered, then the baby has a better chance of surviving without breathing problems. Of course, sometimes we give antibiotics because some of the triggers of preterm labor are infections. And number two, these babies are generally very susceptible to early infections. So we do give antibiotics to mothers who are preterm labor until the delivery occurs. Other drugs sometimes may be given depending on the condition. If the mother has a high blood pressure, have diabetes, we may need to give other medications depending on what is happening. Of course, if we are trying to stop the labor from happening, from continuing, we'll suggest or we recommend that you rest. Usually not complete bed rest, probably just taking, avoiding a lot of activity, which include movement. Don't move around a lot. Spend most of your time resting. when we are trying to stop it. And of course, a lot of psychosocial support is needed, both from the caregivers to this mother, that is family members, or whoever else she stays with, the spouse, her relatives, and the medical people who are taking care of her. They need a lot of support, especially when the labor process is unable to be stopped, and they continue on to get a preterm delivery. So what are some of the preventive strategies or preventive ways how we can try to prevent? Some of the social factors, a lot of women or a lot of ladies, smoking is not a major issue in this part of the world, although that is definitely changing a lot. There are a lot more women who are smoking nowadays than there used to be in the 80s, in the 90s. There are a lot more. And smoking, cigarettes, especially cigarette smoking, cigarettes have been known to have more than 4,000 harmful agents in them. 4,000. And a lot of these basically affect the outcome of a pregnancy in various ways. So stopping smoking, usually before you get pregnant, but even during the pregnancy, if you stop smoking, it has a significant effect on the pregnancy. Other drugs as well, lots of alcohol intake. We say it is better to avoid alcohol altogether in pregnancy. For those who may not be able to avoid, a glass of wine once in a while probably may be safe, but it will be better, to avoid alcohol altogether during pregnancy. Progesterone is a hormone that is produced by the placenta, and its work. It's called the hormone of pregnancy usually. By the name pro means for, or working for. Gesterone is comes from gestation. So something that works for the pregnancy or to preserve the pregnancy. So progesterone is produced by the placenta. It's a major hormone of pregnancy, and it is thought that it helps in keeping the uterus quiet, so that it doesn't subsequent pregnancies. Sometimes we tend to give progesterone supplementation to kind of try and prevent these from happening again. And this sometimes is given as an injection, or sometimes as tablets to swallow. This is usually especially for those who have had unexplained preterm deliveries, and then we are seeing them now in a subsequent pregnancy. So we give them progesterone supplementation. Iron and folate supplementation. We do this for all ladies who are pregnant, because, as I said before, anemia or low blood levels early in the pregnancy, you may end up with a preterm delivery later in the pregnancy. Cervical sacrilege. Sacrilege basically just means closing the cervix with a stitch. You're taken to theater, and a stitch is applied or is put around the cervix and tightened, so that if the cervix is weak, it doesn't start opening up when the pregnancy grows bigger. This sacrilege, or closing of the cervix with a stitch, is usually done early in the pregnancy, usually at around 12 to 13 weeks there, before the pregnancy gets big enough to start stressing the cervix, which may start opening. So you do it very early, so that by the time you're getting to 20 weeks, which is the time usually when the baby is big enough to start weighing down on the cervix, it is already secured with a stitch. Of course, good psychosocial support during the pregnancy. As I said, severe stress from various reasons or other issues that may cause emotional distress, depression, stuff like that may actually lead to preterm deliveries. So good psychosocial support. Pregnancy by itself is a very stressful condition in many instances or for many mothers, and a good support system is essential for a good pregnancy outcome. And of course, as I said, some of the early or preterm delivery is by choice or what you call elective, because of various issues, complications in the mother, complications in the baby. But there are also sometimes, so if you cannot avoid it, you really don't have a choice. You have to deliver even if it's early. But there are times when mothers are also very adamant they want to deliver babies early. Somebody comes to you even at 36 weeks. They say they are extremely tired and they are not going to carry that pregnancy beyond that time. They're tired. They just want that baby out, whatever the case. So, sometimes, some of us healthcare workers accede to that, those kind of requests, and sometimes you actually may end up with problems of delivering a preterm baby. So avoid early delivery unless there's a very, very clear medical indication, even when when the mother may not be very, very comfortable in the pregnancy. I think that is probably all I'm going to say about preterm birth, and I will move quickly to the last topic of the day, which is stillbirth. And by definition, stillbirth means fetal death or the death of a baby in late pregnancy. That is a very wide definition given by WHO, and the reason why it is given like that is it is difficult to define. I said that if a baby is not able to survive outside the uterus when it comes out, then we call that a miscarriage. Yeah. If a baby has reached an age inside the uterus where it can be able to survive outside of the uterus, then we call that, if it comes out, we call it a preterm delivery. Now, what determines whether a baby is able to survive outside of a uterus are various reasons, and part of them are the quality of care, the quality of health care that baby is able to get outside. In some Western countries, babies as small as 400 grams, and at 20 weeks are able to survive outside. They may stay for very long times in the nursery, but eventually they will survive. The death rates are still very high, but some of them do survive. Okay. In our country, a lot of babies, especially in the public healthcare system, are not able to survive when they are born before 28 weeks. Okay. So a baby who is born before 28 weeks, usually we call that a miscarriage. Yeah. Despite the fact that a few of them may be able to survive. If they are born before 28 weeks, we call it a miscarriage. If it's after 28 weeks, we call it a preterm birth. Now, if the baby dies in the uterus before they are able to survive outside, or say they die in the uterus at 24 weeks, usually we refer that as a miscarriage as well. Early death. Yeah? If they die at an age where they could have survived outside the uterus if they were born, then that is what we refer as a stillbirth. I hope that is clear. So in our setup, usually after 28 weeks in the uterus, if the baby dies, we call it a stillbirth. A stillbirth may happen before labor starts, meaning the baby is just inside there, it dies without anything happened to the mother, or it may die even during the process of normal labor. The baby has reached term, 40 weeks, mother is in labor, and then something happens during the process of labor, and the baby ends up dying, during that process of delivery. That is also still a stillbirth. So causes, again, you will see a lot of unexplained things usually when pregnancy is being referred to, and that is because pregnancies are very, very sensitive issues, and unlike many conditions or human diseases, sometimes you are not able, there's some kind of research that you're not able to do on a pregnancy that you are able to do on independent individuals, people. And therefore there are a lot of questions sometimes that remain unanswered, because of the limitations that we have on the kind of research that we can do, or the robustness of the research that we can do on pregnant women. Some of it will not even be allowed. It will not be ethical to do some of the research that can give us answers to some problems. So a lot of problems in pregnancy, remain, unanswered. So up to 50% of stillbirth actually may remain unexplained. Placental issues, as I said before, a significant placental separation or complete separation of the placenta from the uterus will usually result in the death of the baby, unless it happens, by miracle. It happens, and that baby is in a hospital setup, and you're able to rush that mother in and open her up in less than 5 minutes and remove the baby. That the baby may survive. It's happened a few times that I know. But generally speaking, complete separation of a placenta will result in the death of a baby. And complete separation may occur due to many reasons. Very high blood pressures in the mother, trauma, mother falls and she's hit on the abdomen. Maybe it's a motor vehicle accident, or sometimes it's just violence, intimate, partner violence. Sometimes your spouse just hits you during an argument, and the placenta basically just separates, and the baby ends up dead. It could be insufficiency of the placenta. The placenta is not serving its purpose. The placenta is a communication between the baby and the mother, both for supply of nutrients and and removal of waste. Yeah. So if the placenta is not working well or sufficiently for many reasons, like in that condition we call preeclampsia, it's a condition of blood pressure problem in pregnancy. Sometimes a lot of the blood vessels that go to the placenta get blocked, and the placenta is not working as it should. Infarction means death of some sections of the placenta. The placenta is not just one big piece. It's made of several small pieces joined together. So if some of those sections of the placenta die off, and if it's a significant, if you have like 75% of the sections of the placenta dying off for one reason or another, you may actually end up with the baby dying inside there. Infections of the placenta, some of which we mentioned before, malaria, infestation of the placenta, syphilis, that is not diagnosed and treated early enough, may actually end up with a placenta that's not functioning as it should, and a baby may actually die inside there. Baby factors. This could be generally the baby has a problem, and that's why it ends up dying inside there. Genetic or structural abnormalities. Structural just means physical abnormalities. They are not able to survive inside there because they have some abnormalities. Umbilical cord issues. The umbilical cord, it's what connects the placenta to the baby. It is where everything, all communication between the baby, oxygen, nutrients, waste products, That's where everything goes, from the mother to the baby, or from the baby to the mother. So if the problem with the umbilical cord, then you may, if it's a significant enough problem, you may end up with a dead baby. A lot of the time, it's a baby who is not growing well. A baby whose growth is retarded, or restricted, as we say. But if that restriction of growth is really very severe, that baby will actually end up dying inside there. Some of the problems with the cord may be twisting of the cord, knot in the cord. Sometimes when the baby is smaller and they are, they are very active, they are jumping all over the place. The cord sometimes may be very long. You may even end up with a true knot, like the way you tie a knot with a rope. You actually may end up with a knot like that forming on the umbilical cord. And if that knot tightens significantly, then you end up with a dead baby, because they cannot get oxygen from the placenta. Nuchal cords are generally cords that pass through the neck, like they encircle the neck. When they go over the neck just once without doing many rounds around the neck, usually it's not significant. Many babies are born with cords around the neck, and we don't even know they have cords around the neck until when the head comes out and you see there's a cord going around the neck. Yeah. But when you have the cord going many times around the neck, 2 times, 3 times around the neck, a lot of the times the cord tends to tighten around it. When it's going just around just once, it doesn't get to tighten a lot of the times, and that's the time the pregnancy goes all the way. You go into labor, you go through labor, and it's discovered when the head comes out. But if it's tight, if it's going around the neck many times, sometimes it tends to tighten, and when it tightens, then the flow of blood through that cord is impaired, and that baby could actually end up dead. If that process happens during labor, the tightening, because as the baby starts to go down into the birth canal, sometimes that's when the cord tightens. Now, if there's good monitoring of labor, if you are in a good place where labor is monitored properly, then they are able to tell that something is happening to this baby by the mechanism they use to monitor, to listen to the heartbeat or to record the heartbeat patterns. They can see that something is happening to this baby. The baby is getting stressed, and if the delivery is not imminent or they're still very far in labor, most of the time these are the babies or the mothers who end up being taken to theater for cesarean section delivery to save the baby. But if you're in a place where monitoring of labor is not very good, some of these things will be missed, and you will just go maybe to listen to a baby's heart during labor, and you find it's not there. The baby is already dead. So it happens quite a bit. Infections of the baby or the mother or the placenta, these may be various infections. So if they are severe enough in the mother, even if they are not affecting the placenta of the baby, but it's a severe infection that goes, say, to the bloodstream, a lot of times it may actually end up with a dead baby. If the placenta is infected, then its function is impaired, as I've described before, and you will end up with a dead baby. If the baby itself is infected, usually through the placenta, but sometimes through the bloodstream. Sometimes there are 3 ways that the baby can be infected: either through the placenta or through the bloodstream. The mother is infected, and then the infection goes through the bloodstream and goes to the baby, or through the cervix. Sometimes when the cervix is open, and especially when you have the membranes, the amniotic membranes rupturing, and so the uterus is in communication with the outside, you get infections going up through the cervix to the baby, and then the baby is infected, and they may actually die inside there if nothing, if it's not recognized and something done in good time. And then of course you have maternal disease as causes. Diabetes, hypertension. Diabetes is notorious for causing stillbirth, especially when it is not recognized early enough and managed. When a mother is with diabetes, either diabetes before pregnancy or the one that develops during pregnancy, you know, there's actually diabetes called gestational diabetes that develops only during pregnancy. And you know, when the baby is delivered finally, the sugars go down and you become normal again. So it develops only during pregnancy. If it is not recognized or if it is not even looked for, because a lot of times we fail to look for it. If it's not looked for and therefore the baby is exposed to very high sugars inside there, a lot of these babies run a risk of death or stillbirth when they are nearing term in the uterus. So more or less that is what I have for causes. Again, the risk factors are more or less the same as for preterm birth. Smoking features everywhere because smoking is a major what it does in this instance. Usually it will affect placental function. It messes around with a lot of the small blood vessels that go to the placenta, making them narrow or even blocked. And therefore the placenta is not able to function the way it should. Usually it will cause abnormal growth or very slow growth of the baby. So that's such that when you're monitoring the baby, maybe you're doing an ultrasound, you find that the baby's weight is less than it should be for that particular gestation. You're reaching term and the baby is only 2 kilos, you know, because the placenta has been poor in its function because of you know, smoking. Advanced maternal age is a risk factor for stillbirth. By advanced maternal age, again, we have various definitions. Generally, we take it to be 40 years and above. Women who get pregnant when they are 40 years and above are termed as advanced maternal age, and they have a significantly increased risk of getting stillbirth. Mostly because they are also the mothers who have risks for these diseases, like the diabetes and the hypertension. But they are independently also as a factor. Advanced maternal age is a risk for stillbirth. Obesity, you know, when you get pregnant and your BMI is very, very high, for various reasons, you're also at increased risk of getting a stillbirth. Multiple gestation, many babies, 2 or more babies, especially when the babies are sharing a placenta. You know, babies sometimes share a placenta. Those are the ones that are identical twins. And sometimes babies don't share a placenta, meaning they're not identical twins. And those who are sharing a placenta, because there's communication of blood between the 2 babies, sometimes when something happens to one baby, it tends to happen to the other baby as well. Or sometimes one baby affects the other baby. There's blood imbalance between the 2 babies, and both of them might actually end up dead because of that. So multiple gestation, especially when they're sharing placenta. Post-term pregnancy means a pregnancy that goes beyond the date. Generally speaking, as I say, the estimated date of delivery for a pregnancy is about 40 weeks. That is usually the date that a mother is given to expect delivery around that time. The delivery may happen earlier than that by even 2 weeks or more. And sometimes it may go beyond that 40 weeks and labor does not start. Generally speaking, the longer a pregnancy goes beyond 40 weeks, the higher the risk of that baby ending up dead. And so, generally speaking, we do not generally allow a pregnancy to go beyond 1 week after the expected date. Like I'm saying, beyond 41 weeks, the risks increase significantly. So most people will if the mother has not gone into labor by the time they get 41 weeks, some may extend it to 41 weeks and 3 days. That is 10 days after 40 weeks. If the labor has not started by that time, usually we induce labor. We give medications that will bring on labor pain so that the baby can be delivered and reduce the risk of the baby dying inside there. During that time that we extend, after the 40 weeks, the mother may actually need more monitoring of the baby to make sure that the baby is actually okay. Because sometimes the stillbirth will occur without any warning. Today the baby is very okay, you're feeling the movement, and tomorrow there are no movements, and 24 hours later the baby is dead. So they may actually require a bit more monitoring when you extend the pregnancy beyond 40 weeks. Uncontrolled maternal disease, again, the hypertension, the diabetes, the thyroid disease, all those maternal diseases that may interfere with the pregnancy. If they are not, if they are well controlled, if they are not well controlled, they may actually result in a stillbirth. And I say the diabetes is a classic example of those maternal diseases. Preventive strategies for preventing stillbirth. What we call generally preconceptional care or counseling. This is especially for those who get pregnant when they are a bit older. The advanced maternal age that I was talking about. Usually, we want them to attend preconceptional care. So that they're counseled on what to expect and how to go around with the pregnancy. And sometimes you also prescribe, some supplements, folate being a key one. Malaria prophylaxis, malaria in areas where it's endemic. Malaria prophylaxis is actually one of the steps that are in the guidelines of the Ministry of Health. All mothers must have malaria prophylaxis in areas where malaria is endemic. Prophylaxis, I mean giving medications every once in a while to prevent the mother from getting malaria during the pregnancy. Because we know for sure that when pregnant women, when they get malaria, it tends to be more severe malaria, which could actually complicate, not just end up in a stillbirth, but also complicate and even kill the mother sometimes. So the malaria tends to be more severe when it happens in pregnancy. So prophylaxis or giving drugs to prevent malaria is one of the strategies that in the Ministry of Health guidelines for pregnant mothers. Syphilis detection and treatment. Syphilis is always tested for during the first visit of antenatal care. Those that are called antenatal profiles. There are some various, about 5 tests that are done. The blood level, your blood group, the syphilis test, HIV test, hepatitis B test. All of them are done because they are crucial in one way or another for the outcome of that pregnancy or the well-being of the baby. So those are what are called the antenatal profiles, and syphilis is one of them. Syphilis may result in a miscarriage, may result in a stillbirth, may result in preterm birth, all of the things we have discussed today. And even if the baby is born with it and they don't die and you don't have all those things, they will likely have problems later on. problems with their bone system, teeth, the heart, many problems. Hypertension, diabetes detection and treatment, screening for people who are especially at risk. There's a risk profile stratification, the way we look at women who are pregnant and determine whether they are at significant risk of developing diabetes, and therefore we screen. We do some tests to determine whether they have it or not at some stage of the pregnancy. In some countries, in the developed world especially, they screen all women regardless of whether you have risk or you don't have risk. Here, because there's a cost implication to it, we are not able to afford or to screen everybody, so we screen by stratifying the risk. We look at how much of a risk you have of ending up with the diabetes, for example, and if your risk is significant, then we screen you to see whether you actually do have it. Therefore, with this approach, sometimes we do miss a few who may actually have it, and we may end up with problems later, especially if the pregnancy monitoring also is not optimal. Discussion or counseling on danger signs during pregnancy. This has to be a continuing process, especially in the third trimester. When the baby has reached that stage where they can survive alone, that is the stage when we are able to actually do a lot of the monitoring tests that we do for babies. And also, it's this time when mothers are able to feel baby movement very well. So they're able to know. So we explain to them what normal movements feel like, and what will make them feel that the movements of the baby are changing. Fetal movements or baby movements are very crucial, sometimes in determining whether something is happening with the baby. Although they are subjective, that mothers sometimes may feel the baby is not moving while it's actually moving very well. But a concern on movement makes us do further tests to determine whether everything is okay with the baby or not. So every time mothers come for antenatal care, you have to discuss with them this thing we call danger signs. Yeah, what will tell you that the baby is in trouble inside there? Bleeding, abnormal discharge, severe abdominal pains. Reduced baby movements. All those kind of things. We discuss them with the mother so that if any of them happens, they come to hospital for evaluation, and we determine whether everything is going okay or not. Induction of postpartum pregnancy, again, not to let pregnancies go very far beyond the date. As I say, we usually don't let them go beyond 41 weeks or 1 week after the estimated date that you are given. If they are advanced maternal age, women above 40 years, usually we don't go beyond the estimated date. That is 40 weeks. We don't go beyond 40 weeks for women above 40 years. And in many jurisdictions, those women are not even allowed, or they are not even advised to go up to 40 weeks. Some of them may be induced between 38 weeks. After 38 weeks, most people will opt to induce those mothers because the risk is significant. So, and then of course we have other things like stillbirth attendants. Making sure you deliver in a unit where they are qualified people, and the monitoring of labor can be done in a professional way, so that you can detect. A lot of stillbirths happen, during the process of labor, because labor, a pregnancy is almost like a like a flight. When it is taking off and when it's landing, those are the most dangerous periods when something is likely to go wrong. So in the very early stages of a pregnancy, something is likely to go wrong. As we said, that's when most of the miscarriages occur, and then you sit pretty towards the end. Near the end of the pregnancy, again, more complications tend to occur. and especially during the process of labor and delivery. That is where many things can go wrong if the monitoring is not very keen. So skilled birth attendants is important in avoidance as a preventive strategy for avoiding miscarriages. And lifestyle modifications, of course, I mean, taking care of all those things. We talked about smoking, alcohol intake, drugs of abuse, um, exercise, during pregnancy, basically reducing excessive weight gain, diet and stuff like that. Because obesity is associated with an increased risk of a poor pregnancy outcome, whether it's a miscarriage or sometimes a preterm delivery. I I think I probably talked enough. I will leave it at that. If people are still around, if they are still concentrating, maybe we can have comments, concerns, questions at this point.
Hello, thank you so much, Dr. Macharia, for the session on miscarriage, preterm birth, and stillbirth. I really enjoyed a lot. So maybe from the members, I can see one question from Irene Doria.
Hello. I think can't get you clearly.
Sorry. We have a question from Irene Dolo. She's
Yes,
asking,
Irene.
can a pregnant woman who has ovarian cyst has a higher risk of miscarriage?
Ovarian cyst.
Yeah.
Does she have a higher risk of a miscarriage?
Yes.
The direct answer would be no. Primarily because all pregnant women, especially very early in the pregnancy, will have an ovarian cyst. When an egg is released from the uterus, from the ovary, that place where the egg was is left as a cyst. There's a cyst. A cyst is a small space containing some fluid in it. Now, that cyst actually is an important thing in the pregnancy, because before the placenta is formed, that is where the hormones that support the pregnancy are coming from. Until the placenta is well established, and then it takes over the process of providing the hormones. So finding of an ovarian cyst in a pregnancy is not abnormal. Actually, it should be expected, because there's always a cyst where the egg is released from. However, even if that cyst, it is not usually a large cyst. That one is anything about 3 centimeters or so, 3 to 5 centimeters. However, even if a cyst was existing by the time she got pregnant, because there are some cysts that are not as a result of ovulation, even if a cyst was there, it will not usually increase the mother's chance of getting a miscarriage in normal circumstances. No. Is that clear, Irene? Hello?
Hello, Irene, are you answered?
Was there a particular reason why you had that concern, Irene? Hello?
I think if she's not answering, maybe she was answered.
Okay.
Yeah. Thank you so much for that clarification. I don't know, is there any question? Because I'm not seeing any other question in the chat box, and also those following in Facebook, I'm not seeing any other question.
Okay. I didn't actually realize the time moved that quickly. It's only 20 minutes to 8.
Yeah.
All right then.
So
If they are
is there
not,
any question from those who are following? On my side, I can't see any question in Facebook,
okay.
and I also any question in the chat box.
All right.
Yeah.
I think then we can call it a day, and I say thank you very much for listening to me. I am not sure how sometimes people get questions later. I'm not sure whether there's a way maybe they can reach out if they have any queries. That we can work out on. Okay. I think I've tried to be as simple as I could, so that people can understand as much as I. Of course, not as detailed as sometimes we may be because of time, but I think I've tried to be as simple to be understood as possible. Okay, then I think that will be it. Good evening, everybody.
Thank you so much, Dr. Ari. I can see from the comment section, Ivina saying thank you, the class was awesome, and even someone else said, Asani Dr. Macharia well explained. Esther, I've been following and I've learned a lot. Same to those who are following in Facebook, and Mildred, Jacob. So thank you so much, Dr. Ari, for the wonderful session. And with that, I really appreciate. And for the participants, thank you for joining in time, and thank you for cooperating.
Sawa. All right, good evening. Thank you.
Good evening.
Welcome.